Good evening, everyone. So today we'll be talking about shoulder arthritis. Uh, so I think this topic has become quite relevant these days from your practice point of view also, and from the point of view of your exam. I think the national board has raised its bar this year, and the last few years it has shown that it's expecting more and more out of the postgraduate students. To know, at least to know theoretical aspects of sports medicine and also arthroplasty. So lots of questions uh, on shoulder arthritis and shoulder arthroplasty have been coming up in the last few years. So I thought, let's why not discuss this topic. So we're talking about shoulder arthritis, and we'll be focusing more on glenohumeral arthritis. So uh, So, glenohumeral arthritis, as with any form of arthritis, the incidence increases with age. It's more common in women. If I look at my own incidence of doing shoulder arthroplasty, I think it's easily uh, by by at least 5:1 the ratio of women who get themselves operated for shoulder arthritis than men. So quite a number of women, and it's more common in patients who have had shoulder instability. People with shoulder instability are much more prone to develop shoulder arthritis, and they develop arthritis at a much younger age. So you have to keep in mind this form of disease when a patient with past history of instability presents you with constant shoulder pain. So what are the various etiologies? What are the causes of shoulder arthritis? As with any form of arthritis, primary osteoarthritis is one. Not so common in India, Indian subcontinent, in Asian origin people. Much more common is your knee arthritis. But yes, we do see people with primary osteoarthritis of shoulder coming to us. People with inflammatory arthritis, rheumatoid, um, seronegative or seropositive spondyloarthropathies, those kind of people, and patients with secondary arthritis like post AVN because of alcohol or steroids, post capsulorathy or post instability arthritis, that it's after instability surgery or just after instability, patient will present to you with arthritis, post traumatic because of trauma, cuff tear arthritis, neuropathic, especially thinking of some cervical spine disease, patient develops neuropathic arthritis, lots of bone destruction, new bone formation, and post-crystalline, post-gout arthritis. So we're talking about pathophysiology of all these causes. So primary arthritis, it's there is progressive loss of articular cartilage with hypertrophy of subchondral bone. So you see lots of osteophyte formation. The humeral head becomes thin, the cartilage becomes thin out, humeral head loses its shape, there is some chondral cyst. And you have to remember one thing in primary osteoarthritis is that something very peculiar about primary osteoarthritis of shoulder is that the humeral head, there is posterior subluxation of the humeral head. This is very typical. And in glenoid, there is posterior wear of the glenoid. Like in your primary osteoarthritis of knee, you always have your medial joint line, medial joint, loss of medial joint space. And that is very typical of a primary osteoarthritis of knee. What is typical of primary osteoarthritis of shoulder is posterior humeral head subluxation along with posterior glenoid wear. So that is very typical of a primary osteoarthritis of knee. A cuff tear may coexist with primary arthritis of knee, primary arthritis or primary osteoarthritis of shoulder in about 5 to 10% of patients. So we have to look for cuff tears in patients with primary OA also, and you look that clinically and MRI, and so that because you plan your treatment accordingly. So if there is a cuff tear present or not, to change your treatment algorithm totally. You can have post-traumatic arthritis, especially common in patients with uh, proximal humerus fracture, especially your three-part, four-part, and chronic dislocations. Cuff tear arthritis, patients with uh, chronic cuff tears can lead to humeral head superior migration of humeral head and will lead to eventually arthritis of the shoulder also. But this cuff tear arthritis usually is treated very differently than a osteoarthritis or a glenohumeral arthritis. So we'll not be talking much about a cuff tear arthropathy in today's talk. It can be a dislocation or instability arthropathy. One thing to remember is there's higher incidence in patients with posterior dislocation, patients with increased age, and it's not so very well correlated with the number of dislocations. So most important is whether it's anterior and posterior and the age at dislocation. Also, if you do excessive tightening when you do a shoulder instability procedure, soft tissue procedure, then it can also lead to glenoid wear, uneven glenoid wear, and can lead to arthritis. This was more common post capsulorrhaphy arthropathy when we used to do a procedure called as thermal capsulorrhaphy. So we used to do what we used to do. We used to do a thermal necrosis of the posterior capsule, and as a result, the posterior capsule used to shrink, and that led to your shrinkage of volume of the capsule, so the shoulder becomes tight. But this led to a very high incidence of post-capsularrhaphy arthropathy. Not very common these days with the kind of anatomical procedures we are doing these days, but still, it's a form of arthropathy you should remember and should be on your pen when you're writing down an answer. Inflammatory arthritis, like in rheumatoid arthritis, there will be a uniform uh, loss of cartilage, all the part of shoulder, and there'll be soft tissue degeneration also. So in inflammatory arthritis, your soft tissue, your cuff would also be badly affected, and there will be a central glenoid wear, and there will be medialization of single head. So very difficult, very different picture to your primary osteoarthritis of shoulder. Primary, there will be posterior humeral head subluxation, posterior glenoid wear. Whereas in inflammatory arthritis, it's central wear and central glenoid wear and central medialization of humeral head. So inflammatory arthritis like RA or pseudo gout or gout can lead to a arthritis of the shoulder. Also, another cause of arthritis is your avascular necrosis, which can be post-traumatic, seen in three-part, four-part proximal humerus fractures, chronic, unreduced or neglected humeral dislocation, or even after repetitive injuries. May be seen in atraumatic conditions like post steroid use, metabolic diseases like Gaucher's, hemoglobinopathies, or high alcohol intake. So all these are various causes of uh, arthritis of shoulder. One uncommon cause of arthritis of shoulder is something called chondrolysis. I have also personally seen in my practice patients with presenting with chondrolysis, uh, seen in patients with repeated shoulder surgeries. Also, some association has been shown after shoulder arthroscopic surgeries, and we don't know why it's caused, but it's said that it's more common when we use radio frequency energy is used. We use continuous post-op anesthetic infusion to reduce the pain. So when we started treating about two decades back, when arthroscopic capsular release became a very common procedure for your adhesive capsulitis, we started putting in catheters into the intraarticular space after doing the capsular release, and we started pushing in long acting uh, local anesthetic agents like ropivacaine, and these patients after a while came with shoulder significant shoulder pain after a few years.